So, good afternoon, ladies and gentlemen. I will talk about immune deficiency, and I think it's in line with all the other presentations. I have no conflict of interest here. Okay. I will start off with a case, or with 4 cases. The first is a woman of 21 years old, recurrent rhinosinusitis in childhood. She had a mini fest when she was 11. Recurrent infections with fever. CT scan showed some ethmoidal problems, no allergy, and when we do blood analysis, she has very low IgG3. So this was screening for autoimmunity was negative. We did the pneumococcal vaccination. The baseline titers were low. We did then the vaccination, and there was a limited response. So this was a clear case of immune deficiency in that patient. And you also see that the mother has CVID, so actually with the same history. So what did we do? We put the patients on injections with Hizentra, and now it was a good control. Of course, we still had to do some surgery later on, but that was already under substitution therapy. Second case, similar, it's a man of 23 years old, got a severe pneumonia with long hospitalization, recurrent upper-lower airway infections. There was a FES in 2011. We did some workup, and here he had no detectable IgA. Again, a very typical case with a typical history. What should we do further? Well, it was a clear IgA. Should we do further testing? Well, I think you still have to do the pneumococcal vaccination, see whether there is no indication for CVID, and treatment. Of course, this is hard. You don't have substitution therapy for IgE deficiency. So here you have to just take care very well of the patient, do surgery combined with medical treatment. So this is hard because IgA deficiency, you can't give any substitution. Another patient, a woman of 42 years old, she is a teacher. She has recurrent rhinosinusitis with several and otitis media, also some bowel problems. She was referred actually to do a trough 3, but I was a little bit afraid of doing so because I was aware that there was more playing here than that. So this is the CT scan. In the ear you see a perforation, which was very long time perforation, so she had a lot of otitis media. And when we look for several testing, actually we didn't find too much, but we performed some lymphocyte testing, and there was no response to candida and to tetanus. And we always, when we looked in the maxillary sinus, we saw this kind of mucoid secretions all the time. So here we had an indication that she was not really good fighting in fungal defense. So we sent her to the immunologist, and he found out that there was an IL-17 deficiency. It's not important to know, it's just important to recognize that there was a problem. And then the last patient, 4th case, is a woman, 3 times FES. She was in a psychiatric hospital. She had severe nasal crusting, an empty nose, ozena, and there was Staphylococcus aureus there. And actually, we found out that she had diabetes, and this was not really diagnosed. She was in a psychiatry hospital, and they thought, well, she's behaving strange, but obviously it was the sugar going up and down next to the psychiatric problem. So once we did control the diabetes, we could do a surgery, but this stays problematic because of the diabetes. And of course, we know that diabetes gives you secondary immune deficiency. What do we see in ENT? And is that most of the immune deficiencies are antibody deficiencies, and then you have other groups with combined deficiencies and some cellular deficiencies, but mainly it's this group that is easy to diagnose. So you can, around 70% of the immune deficiencies, it's easy for you to do the diagnosis yourself. And I think this is my main message of today, that you should do this kind of testing. So what is there? In the literature, we know that there is immune deficiency. Also, mainly the antibody deficiencies are important. And they account for 50% of all the immune deficiencies. In ENT, if you look in rhinosinusitis, you have in 18% IgG deficiencies and 17% IgA deficiencies. So it is quite common in refractory chronic sinusitis. As you see, some overall reports show between 20 to 23% of some kind of immune deficiency in refractory chronic sinusitis. Before, I was not believing that this was existing, but once you start testing, you start seeing them. And this is my main message. And we always think, well, it should be children that have had it, but it's also quite often after adolescence that you see it. So if you don't test it, you will not see it and you will ignore it. And of course, one of the main messages is you do surgery, and if you do surgery, you can't predict the outcome. And certainly in those patients, it's better to know that there is an immune deficiency before you dig into your surgery. What are two other? So you have the antibody deficiencies are important, and there you have the agammaglobulinemias, the IgA deficiency, the common variable immune deficiency, and some IgG subclasses immune deficiency. The IgE deficiency, as I showed in the case, has chronic lung disease, some atopy, some association with autoimmune disease, and this is very typical for every kind of immune deficiencies, because there is a disbalance in the immune system. They have a higher chance of developing autoimmune disease, so you should be aware of that. Then you have the common variable immune deficiency. What is the definition? That are patients that have a low IgG, which can be combined with low IgA or IgM, and they have a low or an absent response to immunization, for example, with the pneumococcal vaccination, and they have no other immune deficiencies. So this, again, is not very typical, but it typically starts after adolescence, before the year, the 13th birthday. Clinical features is typical sinusitis, pneumonia, some gastrointestinal problems. So if you see this kind of combinations, like you have here, sinusitis, pneumonia, you should be aware that this is a possible diagnosis. So what is now with this pneumococcal vaccination? So if in some patients, you go one step further. So you have done the immunoglobulins titers, and then you can also look for antipneumococcal titers. If there is normal, you don't have to do vaccination. If they are low, you can do vaccination. And here you see in a study where they have done that, and they have, so you have responders and non-responders. So you see, if you start doing this, you detect people with immune deficiency. Why would you do this? Is it because of the response of pneumococcal? No, it's actually because this is a way how you can detect other immune deficiencies. By doing this, you can rule out a whole series of other immune deficiencies. And this is a very important diagnostic way of ruling out a whole series of other immune deficiencies that are hard to test. So that's the reason why we do this pneumococcal vaccination. And here you see, in normal patients, you have normal titers. In responders, you have a nice thing, a nice response. But in the patients with specific immune deficiency, you see that also the immunization with the pneumococcus is not there. What is here? You see a meta-analysis of all the immune deficiencies in chronic rhinosinusitis, and here you see the amount of chronic sinusitis that these immune deficiencies give, like here you see IgM, IgG3. So it is there, and it's widely described in the literature. As I said, there are some typical features. For example, a panhypoglobulinemia give upper and lower respiratory infections. Selective IgA quite often is asymptomatic, but gives also some recurrent infections. And the specific antibody deficiency gives also infections, mostly asymptomatic. So it's not. The typical thing is infection. So what can you do? If you have a patient, you have to go through the 10 warning signs. And I think this is a good start for you if you are not certain what to do in a patient with recurrent infections. You have to go through this list. And I think it's a very important one. If you have 2 or more ear infections in 1 year in an adult, you should think, well, this is not normal for adults. 2 or more new sinus infections within 1 year in absence of allergy. 1 pneumonia per year in more year, chronic diarrhea with white loss, recurrent viral infections, recurrent need of intravenous antibiotics. So if you have hospitalization, recurrent deep abscesses in the skin, persistent thrush or fungal infection, like the patients where we had this IL-17 deficiency, infection with normally harmless tuberculosis-like bacteria, and of course a family history of immune deficiency. So if you have those, you have to, or 2 more of those 10, you have to dig deeper and work together. How should you do that? It's always advisable to work with someone who can do more than you do in that case, but you have to do the first selection for yourself by first the questions. And of course, some things are very easy to do, like a complete blood count, T and B cells you can do. And of course, the titers of IgM, IgA, IgG, and the IgG subclasses you can do. Of course, you can test for allergy. Complement, mannose binding lectin you can do. And then, of course, your vaccination, your titers to pneumo, to Streptococcus pneumoniae, to tetanus, to Haemophilus influenza. And then you can do the response to pneumococcal vaccination. That's all things you can do yourself. And by doing that, you rule out like 70 to 75% of all immune deficiencies that you can detect in an easy way. If you are very certain that there is a problem, you have to work then further with an immunologist. But that's the thing you can do. This is the workout, and I think then the treatment is a burden, because once you have said this patient has an immune deficiency, the GP will always send the patient back to you because I don't know what to do. And it's indeed true that in many cases you can give maybe some substitution with globulins, but quite often you can't do that, and so it's really a burden. What is important for the patient is that the patient has a diagnosis, and I think for your patient that's quite often the story. At the moment they are knowing that they have an immune deficiency, that changes their lives. We had the case with a teacher, and she was teaching, and the director of the school always said, well, everyone can be sick, but you are very often sick. I think you rather don't like to work. Do you have a depression? Do you have problems? And finally, she got a diagnosis, and so the school authority said, well, we will just give you another job without the children. So I think for that patient it was important. So my main message is, if you do a lot of surgeries and you see some infections and some patterns, as I've shown, think twice. It doesn't mean you don't have to do the surgery, but be aware that immune deficiencies are quite common in refractory chronic sinusitis, so in 23%, which is not a small group. And it's actually not so difficult to dig in. You can, for 70% of the immune deficiencies, 75%, you can do the diagnosis yourself. So you should test for antibody disorders, and you should also, of course, look for the secondary immune deficiencies. It can, of course, be HIV and leukemia, but diabetes is a very common one. So just do it, test it, and I will promise you that you will see more immune deficiencies than you initially thought you would ever see. Thank you very much.